Good evening, everyone. After a long period of time, I'm going to discuss again one video on the topic Myasthenia Gravis, which comes in your pharmacology book under ANS and cholinergic drugs. Myasthenia Gravis topic I'm going to discuss with you. And before I start my video, I want to request you if you like this video and if it is helpful and useful to you, kindly subscribe to my YouTube channel. That is Dr. Nitika Pharmacology Discussion. Now I'm going to discuss with you myasthenia gravis. So, what is myasthenia gravis? Basically, it is the autoimmune disorder in which there is a skeletal muscle fatigability and weakness. Why? Because antibodies are formed against the nicotinic receptors, that is the NM receptors, which get stimulated on the action of acetylcholine on the NM receptors, and these antibodies, that is IgG antibodies, are formed and they bind to the NM receptors to the of the they bind to the NM receptor of the post-functional motor end plate, and thus the action of acetylcholine is prohibited. So antibodies are formed against nicotinic NM receptors of the muscle motor end plate. So there will be less action of the acetylcholine on NM receptors. So that will lead to weakness of the uh, muscles. There will be twitchings, fasciculations, weakness, fatigability. So this is how it acts. Antibodies are formed. Antibodies are formed against nicotinic receptors. These antibodies, this is acetylcholine, and these antibodies are formed against and they bind to the nicotinic receptors, that is NM receptors of the muscle end plate, and thus action of acetylcholine doesn't come. So incidence, it is 3 to 4 per million, and it is basically seen in 15 to 50 years of the patients of this population, and females are uh, ex- uh, are more affected as compared to males. Prognosis is worse if myasthenia gravis plus thymoma is present. Now, what will be the clinical feature? Clinical feature will be there will be weakness of the muscles, and basically the weakness of the facial muscles, of the pharyngeal muscles, of the eye muscles are affected earlier as compared to abdominal, limb, or respiratory muscles, and there will be fatigability of the muscles on repeated activity, and there will be recovery after rest. Symptoms intensify toward end of the day or following exercise, and intermittent. And when the eye is affected, there can be seen ptosis or diplopia can be seen. This is how there is ptosis of the patient in the myasthenia gravis patient. And there is also weakness of the pharyngeal muscles and facial muscles, so there will be difficulty in chewing, swallowing, speaking, and limb movements. Shoulder girdle muscles will also be affected. Severe disease involves all muscles, including respiratory muscle weakness. Means in the end, the respiratory muscles are also involved. Day-to-day variation in signs and symptoms. So, mortality is because of failure to breathe, because of the paralysis of the respiratory muscles. There is difficulty in breathing, so that can lead to mortality. Myasthenia gravis patients are sensitive to action of the chloroform drugs and other drugs that interfere with neuromuscular transmission like aminoglycosides and antibiotics. So, diagnosis, it can be by anti-acetylcholine receptor titer by immunoprecipitation assay. Means we can know the antibodies against acetylcholine receptor. We can go do EMG recording or adrophonium test. Adrophonium test is, now adrophonium is the acetylcholinesterase inhibitor. That is, it is the anticholinesterase. And it is rapid acting and it is short acting. So when we give the adrophonium in the myasthenia gravis patients, So there will be rapid action, and there will be acetylcholine will not be broken down. Acetylcholine more accumulate hota in the body. It will be more accumulated in the nerve muscle and plate. So there will be improvement in the muscles. So there will be more contractions. So, myasthenia gravis shows improvement in muscle strength for 5 minutes. And adrophonium, when we give 1 to 2 milligram IV adrophonium, it is rapid and short acting, and it is very instant action it will be producing. So acetylcholine levels will increase, so myasthenia gravis patient's condition will improve. And if the patient's condition improve, it shows that the patient is having the myasthenia gravis, because the condition of the patient improves only in the myasthenia gravis patients and not in other muscular dystrophies. Means when we give adrophonium, effect comes only in the patients of myasthenia gravis and not in muscular dystrophies. So, management is symptomatic. We can give with the drugs like acetylcholinesterase inhibitors like neostigmine, pyridostigmine, adrophonium. Immunosuppression, we can decrease the levels of antibodies in the body, and we can also do the thymectomy. This is how we proceed from mild to severe disease. Now, symptomatic treatment is boost amount of acetylcholine level. So this can be done by the acetylcholinesterase inhibitors. They will prolong the duration of action of acetylcholine. So there will be more contractility of the muscles of the motor end plate. Acetylcholine levels will increase. So acetylcholine receptors will be more stimulated. First drug is pyridostigmine. Its starting dose is 30 milligram 3 times a day. More rapid in action, can be used in morning to make the patient mobile. Sustained release preparations are available. Means once daily dosing, sustained release preparations are also available. Should be used at bedtime only. And only symptomatic treatment, but in some patients, is the only therapy needed. So it can be oral, sustained release, or it can be given IV. Longer duration of action, less frequent dosing, effects after 15 to 30 minutes taking the dose. Now, after pyridostigmine, we can give neostigmine 15 to 30 milligram per day orally, or zero point 0.5 to 2.5 milligram IM or subcutaneous injection is also available. Ambinonium, it is available in 2.5 to 5 milligrams 6 hourly orally. So all these are anticholinesterases. They increase the levels of acetylcholine in the muscle and plate, leading to improved contractions of the muscles because they increase the levels of acetylcholine. So what is cholinergic crisis? It is the when we give the acetylcholinesterase inhibitors, and we give the more dose of the acetylcholine in the patient of the myasthenia gravis only. Uh, when we give more dose of the acetylcholinesterase inhibitors, now there's already the weakening of the muscles is there, and when we give more dose, the acetylcholine levels will more increase in the nerve muscle and plate, and that can lead to depolarizing blockade. That can lead to depolarization of the nerve muscle and plate, because levels of acetylcholine will increase, and that will lead to cholinergic weakness, cholinergic crisis. Means more acetylcholine can lead to depolarization of the nerve muscle and plate, leading to more weakening of the nerve muscle, motor end plate of the muscles, leading to cholinergic crisis. And myasthenic crisis is when it can be essential to distinguish excessive drug therapy, cholinergic crisis, from severe myasthenia. Myasthenic crisis is when the patient is suffering from myasthenia gravis, and we get the acetylcholinesterase, and that is the adrophonium. If there is improvement of the patient, or that is the contractions of the muscles are there, or the weakening is reduced, that there's improvement of the myasthenia gravis is there, so that is the myasthenic crisis. And Means the patient is suffering from myasthenia crisis. And if we give the hydrophonium and there's worsening of the symptoms, means there is weakness in the muscles, so that is the cholinergic crisis. This is the same thing. Cholinergic crisis, we give hydrophonium. There is worsening. And in the myasthenic crisis, means patient of myasthenic gravis, and we give hydrophorium, there will be relief of symptoms because the levels of acetylcholine will increase in the muscle and plate, and there will be relief, there will be more contractions. So this is how we see cholinergic crisis can precipitate the respiratory failure also. And then the cholinergic crisis can be treated by resuscitation and mechanical ventilation. And we can give the withdraw all the anticholinergics, and we can do the mechanical ventilation. We can give atropine for muscarinic effects of overdose because acetylcholine levels are increased. So to reduce the muscarinic effects, we can give IV atropine. So resistant myasthenic crisis, again we can withdraw all the drugs. We can do mechanical ventilation. We can do plasmapheresis. Plasmapheresis is removing of antibodies from the circulation. And we can give IV globulin in removing the anti-receptor antibodies. We can give IV immunoglobulin, which removes the anti-receptor antibodies. So immunosuppression can be done by prednisolone. It is the directed at eliminating acetylcholine receptor antibodies. Means we will eliminate the anti-acetylcholine receptor antibodies, and thus the levels of the nicotinic receptor will increase, and it induces improvement or remission in the 80% of the MAS cases. And immunosuppressive improvement may take several weeks. Prednisolone is effective for ocular myasthenia, while thymectomy and anticholinergic drugs are not effective. Where means in ocular myasthenia, the prednisolone is effective. Now, next drug is azathioprine. It blocks the cellular proliferation. Means it inhibits the T lymphocytes, and so acetylcholine receptor antibody levels are decreased with azathioprine treatment. And it's used in the relapsed cases while on prednisone or as a steroid sparing agent. Taking prednisone for long periods of time, we can give the patient who doesn't want to continue on the steroids, we can give azathioprine, which is another immunosuppressant. Beneficial effects can be seen, not seen until after 18 months. Is teratogenic, can impair fertility in the woman. It is teratogenic and it can impair the fertility in the women. So next drug is cyclosporin. It's quicker acting, 1 to 2 months. It also inhibits the T lymphocytes. Suppressor T lymphocytes are reduced, and blocks the production and secretion of interleukin 2. Adverse reactions are hypertension, hyperglycemia, nephrotoxicity, hyperkalemia, seizure, hirsutism, tremor, gum hyperplasia, paresthesia, anemia, hepatotoxicity. They also decrease the levels of antibodies against the acetylcholine receptors at the nerve muscle end plate. Now, mycophenolate mofetil, it blocks the purine synthesis, suppress T and B cell proliferation. So, well tolerated in most patients, myelosuppression can occur. Cyclophosphamide can also be used. Now, what is the intermittent or chronic plasmapheresis? It is the procedure that removes acetylcholine receptor antibodies from circulation. Established therapy in myasthenia crisis. Improve strength if necessary in patients prior to undergoing thymectomy. Means prior to undergoing thymectomy, we can do the plasmapheresis, which is removal of antibodies from the circulation, which are anti-acetylcholine receptor antibodies. Effects of a course last only several weeks. Are susceptible to hypertension and in individuals at risk of myocardial infarction. So IV immunoglobulins, these also remove the circulating anti-receptor antibodies. No clear-cut efficacy proven. Advantages: they have a low risk of side effect compared to immunosuppressive medications and plasmapheresis. Because they also remove the circulating anti-receptor antibodies. Mostly, most side effects they are related to rate of infusion, including headache, lightheadedness, chills. Uncommon but significant thrombotic events, including myocardial infarction, stroke may occur. Thymectomy is just the surgical removal of the thymus gland. It produces gradual improvement in majority of the cases. It produces the gradual improvement in majority of the cases. It is found to contain modified muscle cells. Now, what the thymus gland is known to contain modified muscle cells with nicotinic receptors on their surface, which may be a source of the antigen for the production of anti-nucleotide antibodies. So, they are modified muscle cells are present with nicotinic receptors on the surface, and they are the antigen to the antibodies. Again, nicotinic receptors, uh, nicotinic receptor antibodies in myasthenia gravis. So when we remove these muscle cells with nicotinic receptors on the surface, which are antigen, so they will lead to less production of the antibodies. So response to thymectomy is not limited. Only 20%, 25% achieve remission in first year, 40% in second year, and 55% in third year. So this is how the effect comes. Pyrrhosigmine effect comes in 10 to 15 minutes. Plasmapheresis, this is removal of the antibodies from the circulation, comes in 1 to 14 days. IV immunoglobulins, which also remove the antibodies, so they come in 1 to 4 weeks. Prednisolone, which is corticosteroid, 2 to 8 weeks. Mycophenolate mofetil, 2 to 6 months. Cyclosporin, 2 to 6 months. Azathioprine, 3 to 18 months. The effect comes. Thank you. That's all with myasthenia gravis and its diagnosis and its clinical features, its diagnosis and its management. I hope you understood this video, and if you understood this video and if you like this video, kindly subscribe to my YouTube channel, that is Dr. Nitika Pharmacology Discussion. Thank you.